So today we've got our What to Expect Following Surgery webinar with Dr. Neil Fenn and Katherine Reed from the Department of Urology at the Swansea Bay University Health Board. So thank you very much for being here with us, guys. And I think that's about it. Oh, just to let you know, there might be, because we're talking about surgery on the slide, I mean, Neil, you maybe will cover it, but just so people are aware, there are some graphic images. All right. So over to you guys. Thank you.
So my name's Neil Fenn. I'm a urological cancer surgeon in Swansea. Have been for the last 25 years. And through the majority of my consultant career, I've concentrated on renal surgery, and hence the invite to talk today. We've also got Kath with us, Kath Reed, who's our kidney cancer CNS, and you'll see her mention it multiple times. And then a little bit towards the end, she has a slide to highlight the aspect of her work and so forth. And then I'm sure she'll be available for the questions. Now, so as an introduction, the last 3 decades have really seen an unprecedented developments in renal cancer. We've seen an increase in incidence, which continues sadly. So over the last 10 years, there's been a roughly sort of 40 to 50% increase in the number of cases we see. This is for a number of reasons. The raw or crude incidence rate is certainly getting larger. We have an aging population, and of course we have lots of imaging modalities, and patients often have body scans for vague or other unrelated symptoms, and we pick up small renal masses within that structure, classically CT colonograms used for screening for any change in bowel habits, and also a lot of our cases come from other MDTs, such as the lung cancer MDT. In addition to the increase in incidence, as I've mentioned, there's been a change in presentation from a classic triad that I would have been asked about when I sat my final urology exams in 1999, whereby the majority of renal tumours presented with a classic triad of loin pain, so pain in the side, maybe a detectable mass on examination, and blood in the water. However, we rarely see that classic presentation, as the textbooks would call it, and the majority, as I mentioned above, are now incidental findings with imaging for other reasons. What has come with this shift from the symptomatic presentation to the incidental is earlier diagnosis. And with that, you have a stage migration. And what I mean by that is that the tumours we see now are often smaller at presentation than those that we saw historically. At the same time, however, nearly 40% of the cases we see are in the over 75s. Now, I'm approaching my retirement, and I'm very keen to survive for a little bit longer to enjoy that. But you have to also realize that sadly, with advancing years comes other comorbidities, and these all have to be factored in when we're thinking about the treatment that we may offer. Over this 3 decades that I've been in post, has been a huge evolution in surgical treatments, where the concept of less, not more, is certainly, as you'll see from some of the slides that later on in the presentation, is certainly the case. The other huge change has been our understanding of the biology of renal tumour growth, and this has led to new systemic treatments, i.e. treatment for advanced disease, which can't be cured purely by surgery. As I said, when I was appointed as a consultant, we had very little to offer patients who sadly had progressed, but now through the understanding of what's actually going on at a cellular level, the first group of treatments we had were the so-called tyrosine kinase inhibitors, and more recently we've had immunotherapy, which we'll make mention of later on. And then the final change that's occurred is what we're seeing today: improved patient awareness and support. And it'd be fair to say that we didn't really have much in the way of support when I first started as a consultant, both for patients and their relatives, but that's certainly evolved as much as the tumor factors that we see above. What I want to concentrate on the rest of this is looking at the evolution of surgical treatments, less and not more. And at the end, we'll just talk a bit about patient awareness and support. So what about historical perspectives? So in fact, the first nephrectomy was performed by a chap called Walcott in 1861. He actually thought he was removing a hepatoma, which is a tumor of the liver. Of course, don't forget, in 1861, we didn't have ultrasound scans, CT scanning, or PET scanning. That this was all on clinical diagnoses. The other thing we didn't have, I don't think, was an anesthetist. So I think this picture, which sadly looked like the patient's having much in the way of analgesia. But the first planned nephrectomy was performed by Simon in 1861. Now, there, as mentioned at the beginning, there are some pictures that are a little bit, which are surgical in nature, but nothing of any patients. And here's the first one. So essentially, through the early 19th century, various types of operations were done. It wasn't until Robson and colleagues in the 1960s looked at the way that we were performing nephrectomies the various ways, and after a bit of research showed that the standard or gold standard curative treatment for renal cell cancer should be a radical nephrectomy. And this involved the early ligation of the renal artery and vein. So you're quickly cutting off the blood supply to the kidney. So that should reduce any blood loss during surgery and also any spread of tumor cells. You not only remove the kidney, but you remove the kidney in its surrounding envelope of fat. And you see from this specimen, so all the specimens of patients are mine. There's no identifiable labels on them, but they're all specimens that I had removed early in my career when the pathologist took great pleasure in taking pictures, and we kept them in the patient's notes. That sadly is one of the changes that has occurred in the NHS, that this no longer happens. But this was a radical nephrectomy. You can see that you can't see the kidney in there. It's surrounded by Gerota's fat. And so we're keeping the kidney well away from any of our margins, as it were. We would have taken out the adrenal gland, which sits within Gerota's fascia, and we would have also taken out the lymph nodes. And really, from the 1960s until the 1990s, this was the operation that we all did. Downside of an open radical nephrectomy was that it required a major incision, and these incisions could either be a midline abdominal incision, it could be a subcostal incision. So you can see on these pictures here that essentially we can have a rooftop incision here for big tumors. You can see a thoracoabdominal, but the majority of patients had some form of loin incision, we can see on this lower picture. And you don't need to be medically trained to realize that a cut that's coming from the abdominal wall through into the ribs is likely to result in a fair amount of pain post-operatively. And that was one of the major problems with open surgery, is the significant need for post-operative analgesia, in addition to the perioperative complications of bleeding. If you have a big cut just below your ribs and through your ribs, then there's a risk of chest infections after surgery, and also the increased risk of clots in your legs and Ps, which we would term VT. So good operation, but sadly, it was the post-operative care and post-operative course that troubled many patients. But there has been a change in paradigms in the surgical management of renal cell cancer. And apologies, I should have warned you. This is another picture. These again, two specimens of mine. This was a nephrectomy that I performed literally in my first week as a consultant. The patient had a large renal tumor that was replacing most of the lower pole of the kidney, measuring like 12 centimeters, and obviously required an open nephrectomy for that. Compare and contrast with a patient about 5 years later. We're starting to see some of the shifts in stage migration. Here we see that there's just a small tumor in an otherwise normal looking kidney. So it's always been the question as to why are we removing the whole kidney when in fact could we just be treating the kidney lump itself? So what have been the changing paradigms, and what are the drivers for change? Well, The first thing, as I mentioned from those pictures, we're starting to get earlier stage presentation. There'll be a number of sorry, wrong, didn't mean to do that, sorry. A much larger proportion of tumors in older patients. We have the concept of why do you want to remove the whole kidney when most of the kidneys we could see in that second picture I showed you a little bit earlier. Could you just remove the tumor? Because we know that reducing somebody's renal reserve, how much renal tissue they have to function, has a detrimental effect on their health. And also with the other driver of a change is there was a general drift towards minimally invasive or minimal access surgery. And this has led to an evolution in our treatments. So when I started, you either got an open radical nephrectomy or nothing. Whereas now we have, as you'll see here, a whole tranche of different treatment options that are possible in patients. And what it's important to say is that it's not a case of one size fits all. Each patient that we see in our MDT or via our multidisciplinary team, we will look at their particular case, the way they presented, their age, their comorbidities, so what other medical problems they have, and then try and tailor the options to their specific needs. We know, for instance, in elderly people with other comorbidities and small renal tumors, we often don't treat them at all. So akin to prostate cancer, where we talk about patients dying with their prostate, not because of their prostate cancer, it is the same in older patients with small incidental lesions that we will just keep an eye on them, knowing full well that it is unlikely that that lump will ever become clinically significant. In our aim to try and leave as much renal tissue behind after treatment, we can use various ablative techniques, and I've got some pictures in later slides. So we either use cryoablation, which is using freezing, or radiofrequency ablation, which is where we heat the tumor up. And why these ablative treatments can be used in renal tumors is the fact that, as I showed you from some of the earlier pictures, the kidneys are surrounded by a nice envelope of fat, and they're rarely abutting adjacent organs directly. So that gives us the ability to either freeze or heat the lump itself up within the kidney, whilst leaving the remainder of the kidney and the surrounding structures untreated. If that's not possible, we could always think about just removing the lump, and we call that a partial nephrectomy. However, there will be some patients in which the above three options are not possible, in which case we will proceed on with the radical nephrectomy, and the majority of those are done with laparoscopic surgery, so keyhole surgery. There's still a role we'll see a bit later for an open nephrectomy, however, and very occasionally we have so-called stage treatments, whereby the patients may initially have some oncological treatment to try and downstage their tumor to make it smaller and treat the surrounding lymph glands and perhaps pulmonary disease, and then we will proceed with surgery. So you can see there's a lot going on with regards to treatment options compared with where we used to be. So briefly, ablative therapies or ablative techniques, well, these are truly minimally invasive. And essentially, I'm not sure whether you can all see that, but in the top picture, you see there's four pictures. So this is a laparoscopic view of a kidney. The tumor is marked very nicely with tumor. The fat's been stripped off it. And these cryoprobes are placed into the lump. There's two of them in there. And there's also a laparoscopic lateral probe out here, which is essentially keeping an eye on the ice ball. And then in picture C or picture 3, you can see the cryoprobes have frozen the tumor. It's now a nice ice ball. And then we do freeze thaw techniques. So we'll freeze, then thaw, then freeze, and then thaw again. And that double cycle is the most toxic thing to cells. And what we're trying to do here is freeze the lump and a small rim of surrounding renal tissue without damaging the rest of the kidney. This can actually be done percutaneously as well. So this one is a laparoscopic, but these days we're also radiologists are performing cryotherapy percutaneously under local anesthetic as a day case procedure. And the other ablative therapy, which is the lower picture down here, this is actually a small tumor, and this patient is about to have some radio frequency ablation. So in this case, we're going to heat the tumor up to destroy it and try and leave the remaining kidney preserved. So what do we know about these minimally invasive approaches? It can be done under a general anesthetic, or in certain cases, local anesthetic and sedation. During my 25 years, we're starting as a consultant where we did some laparoscopic cryo early on, is that we now got some long-term data to say that in selected cases that these ablative techniques are very attractive. There are some downsides. Really, you should only be treating lesions that are 3 centimeters or below. They do push the boundaries a little bit with cryotherapy, where we can treat lesions up to 4 centimeters. And of course, there may be variable service provision across the UK because the numbers of cases are quite small. For instance, in South Wales, this service is centralised in one of our hospitals along the South Wales corridor, along in Newport, where we have 2 interventional radiologists who provide the service for the whole of South Wales. So that's, again, a good example of team working. And rather than everybody having a go, we've all got together, sat down and said, right, who's got the facilities, who's got the expertise, right? We'll work out some funding streams, and it works very nicely for our patients. So ablative therapy, if you can't ablate, can we just remove the lump? And we would call that a partial nephrectomy. And in fact, we did these for many years, but it was still an open operation. So all the problems we had with the open radical with regards to the wound and the post-op pain relief. However, the big sea change here was when we started to do these laparoscopically, and more recently, the concept of a robotically assisted partial nephrectomy. In the 2 pictures we see here, you can see in the picture on the left-hand side of the screen, the fat has been stripped off the kidney again. Essentially, the lump is here in the middle. The surgeon has scored around the outside where they think they need to cut. So they're going to cut with a rim of normal tissue and remove the lump. On the picture on the right-hand side, you can see the defect in the kidney that's been left. One of the downsides of any kidney surgery, especially if you're cutting into the kidney, is that about 25% of every heartbeat goes to the kidneys. So they're a very vascular organ. So what you have to do is you have to suture, and you see the surgeon here with the robotic suture holders is actually suturing the blood vessels. And there's a little bolster which is in picture 1 over here, which is a Surgicel, which is a coagulant dressing that will be put into that defect, and the stitches will be closed over it to prevent any bleeding. So that's a huge advance, and really now what we have is 5 and 10-year data confirming that in selected cases, currently for lesions that are 4 centimeters or below, although it is slowly expanding into lesions which are 4 or 7 centimeters, have to be in the right position within the kidney. And these ablative and partial nephrectomies are particularly good for patients who have a limited renal reserve. They've already got an element of renal impairment, and what you're trying to do is spare as much renal function as normal. And again, the numbers are relatively small. So in South Wales, we have 1 unit, which will be Cardiff, that does our robotic partial nephrectomies, and we have a partial nephrectomy MDT. So you can see we've got the networking really well developed here down in South Wales. Then, of course, still the majority of patients, sadly, the tumours are still bigger than the 3 or 4 centimetres. And in those patients, they will end up having a laparoscopic radical nephrectomy, first described in the 1990s. And then I went over to the States, to the Cleveland Clinic in early 2000 to do a fellowship to learn how to do this, and brought it back to South Wales and was the first surgeon to perform this type of surgery. And I've now trained pretty much at least 1 registrar in every unit in South Wales, and more importantly, all around the UK. And the real reason that this operation has worked is we were doing exactly what we were doing with with an open radical nephrectomy. So we were doing the same maneuvers, same principles that Robson set out in the 1960s. we were just doing them as this picture shows. Instead of our hands being in the patient, we had the instruments in the patients, which are small little ports. And again, this is one of my patients. So this is somebody who's had a laparoscopic right-sided nephrectomy. So you can see there's some small little cuts where the ports were. This gentleman had had an appendicectomy as a child, so I just extended the appendicectomy scar up to allow me to extract the kidney out. And compared with those open cuts that I showed you in the one of the previous slides, these small little keyholes and one extraction site have far less pain attached with them. And you don't need me to tell you, just to tell you that it is a laparoscopic nephrectomy as better than an open nephrectomy. There have been numerous studies from Europe, Japan, and North America. This is just one that I tend to pick out. It's compared to 112 patients, of which 41 had lap, the remainder had open. All the patients were comparable in terms of age, their size, and the tumor size. And the laparoscopic group had a much less blood loss, decreased analgesic requirement, shorter hospital stay, good for everybody, and a more rapid return to everyday convalescence. And what's more, the 5-year survival data was exactly the same in the two groups. There is still a role for open nephrectomy. Sadly, despite public awareness campaigns of Kidney Cancer UK and so forth, there is still a number of patients who present with larger tumors, and essentially these tumors, and I don't know quite what's happened there, but one of my pictures seems to have cut off a bit there, but this X-ray was of a larger tumor, and they may even have extension, as we can see here, potentially into the IVC. So in these patients, we still require traditional open surgery. So look, I've talked about, sort of try to set the scene a little bit for you all in the audience, to say that it isn't just a case of patients got been diagnosed with a kidney tumor, let's get it out. You can see there are lots of different treatment options, and we have to tailor those treatment options to the individual patient. So what can you expect after surgery? Well, in fact, after surgery starts before surgery, all right? So what I can tell you is that all patients, before I see them in the clinic, we would have seen them in the MDT, discussed their case in the MDT, where we looked at their imaging and looked at their past medical history and other comorbidities that are going on. We may have, from there, we'll decide what we believe to be the options available for that individual patient. We may on occasions get additional tests, but generally most patients will have everything we need for me to then see them in the outpatients, where I will review them with the aid of Kath, their key worker and CNS. The discussion is verbal. However, as you can see from this slide, BAUS, which is the British Association of Urological Surgeons, have been very proactive starting in and around the COVID period, and just about every surgery and most of the diagnoses we have in urology, BAUS have kindly developed these patient information sheets, which are agreed and have been rolled out across the whole of the UK. Most of these booklets are 7 pages, and it goes through the key points on the first page. It'll then take you through the operation itself, what the alternatives are, and it puts all the potential side effects in little graphs so people can understand them. We've even made it into the 21st century, so I get this information sheet up on the screen in outpatients, and I ask the patients if they want to QR code it, which they do. Then we're also saving the planet by not printing out lots of written information. So following that discussion, provided with written information, we will give you, you'll meet your key worker, Kath, and we'll provide you an ability to give her a ring. Are there any questions? What of the options we've discussed? You know, what would you like, and so forth. And generally that sort of provision of verbal, written, and then post-outpatient support is what most patients respond to well. There may be a need for other specialist review before we get onto the treatment options. especially if we're going to do still do something like an open radical nephrectomy if the patient has a large tumor, so there need to be an anesthetic review. Some patients will already have a poor renal reserve, so taking out a kidney or treating a lump may affect that detrimentally. So we may have to see them, get them to see renal medicine. Very occasionally, patients may have been born with or have had another one of their kidneys removed prior to them getting a tumor, and that they may end up having to require dialysis afterwards. So renal medicine here in Swansea, we have a close working relationship, and of course oncology, because there will be a small number of patients that we may need to see, that they may see them before we operate on them. What about in hospital? Well, things have certainly changed. Most patients are admitted on the day of surgery. You'll be seen by the surgeon. We go through further discussion just of any questions that may have arisen since the outpatients. Patients will be consented and will be marked, so we'll have their x-rays available there with the patient, and we mark the site to be removed. One of the things that we start the VTE precautions, so patients will be given some very attractive TED stockings to wear. So those are the nice white thromboembolic stockings to help prevent DVTs, because patients are on the table for 2 to 3 hours. And then in my practice, I do 2 laparoscopic nephrectomies in a day. So the patient who's on the afternoon will be allowed to drink, so sip until surgery. So no longer are they patients starved and dehydrated for long periods. We allow them to drink water and up until they come to surgery, and that's found to be very good for them. Post-procedure, the majority of patients will come back to the wards. Some will go to high dependency. And of course, if they're having a day case ablative treatment, they may get discharged the same day. A number of surgeons over the years in the UK have tried day case laparoscopic nephrectomy. I know the Stoke group, which was headed up by one of my old registrars, certainly did some, but most patients, because of their age and the length of the operation and the general anaesthetic, especially if it's an afternoon case, will need to stay overnight. They'll all have a catheter in, may have a drain to drain the operative site, but the catheter is removed first thing in the morning and drains will be removed at a similar time. We concentrate on pain relief post-operatively. So in my practice, the patients will have a spinal anaesthetic when they're asleep and so-called lashings of local anaesthetic in the port sites. So to try and minimize the need for significant opioid medication after the operation. As far as nutrition is concerned, patients are allowed to drink and then eat on the after their operation on the same day. So often have come around in the evening to see the morning case on a Friday, and they'll be tucking into a nutritious NHS sandwich, he says with a smile on his face, and be having a cup of tea. All patients, in addition to the stockings that we spoke about, will have a dose of subcutaneous heparin starting on the first night of the night of the operation, provided there's no bleeding problems. And in line with guidance, they will continue on daily injections of heparin to thin the blood slightly to prevent clots in the legs. And that's continued for 28 days post-operatively, and patients will be taught how to self-inject, and we give them advice with regards to wound care. Now, I would say they would be discharged with arrangements for the district nurses to see them, which is what this picture is all about. But these days, they have their key worker. If we need to see them, we tend to just see them ourselves, because they'll contact Kath and say, look, I'm having problems with this, that, or the other. And we'll say, great, just come along to the surgical assessment unit. So we cut out the middleman, or the middle woman in this case. So what about follow-up? What can you expect? Well, this will very much depend on what the initial treatment is, what the pathologist tells us about the tumour, and whether there's a need for oncological input. So what we tend to do, and we'll explain this to patients, is we risk stratify a patient post-operatively based on their pathology report to give us a Leibovitz score. And that is put into the EAU guidance. What the Leibovitz score is able to predict what is the risk of this person sadly developing a recurrence during their follow-up period. And what that allows us to do, depending on whether that's high, medium, or low risk, is to tailor a particular follow-up regime, which are outlined in the EU guidance, for that individual patient. And really what we mean by tailoring is how regularly are we going to do it, particularly in the first 2 years when most recurrences tend to occur. And there'll be a combination of clinical review, blood tests, checking on the other kidney, making sure the liver and bone profile are fine, and then CT scanning. And generally, the first one will be at 6 months for the low risk. Once we get into the intermediate and higher risk, they'll have their first scans. Well, if they're high risk, they'll have them straight away because they'll be referred on for consideration of immunotherapy. But they'll have a much shorter gap between their scanning. Once a patient is stable in the follow-up period after the initial face-to-face, then if they're happy, then we tend to do this follow-up remotely, and Kath leads on that. So she will arrange their next scans, their next blood tests. The patients let her know once she's had them done. We look at the results. She lets them know, yes, everything's fine. Your next one will be doing X, Y, Z. Are you fine? Is there anything you need to come and see us about? And if not, then they're out in the community and happy to lead a normal life. During follow-up, especially at that initial clinic, some patients will require onward referral. So if patients are young at diagnosis, between 40 and 45, we will refer them to the genetics team in Cardiff. For us, again, a regional centralisation for some genetic testing. We'll mention oncology in the next slide, and then there may be a need for renal medicine involved, especially if we've had some, essentially there's some problems. One final slide, problems with their renal function. One final slide, which has been a big change, is a small number of patients that are deemed to be high intermediate or high risk of recurrence will now will be offered, if they're fit enough, adjuvant treatment. What do we mean by adjuvant treatment? This is additional treatment that's given after surgery, and it's really clinical trials that have only recently shown that there is a survival advantage in those high-risk patients if they receive immunotherapy in the adjuvant setting. That always has to be the treatment is with pembrolizumab, given, as you see, by an infusion every 30 minutes, given every 6 weeks for a total of a year. And then patients will be followed up by the oncologist for 3 years. Treatment's just given locally, so along the South Wales corridor in all of the units that have chemotherapy day case. Although I may do surgery for patients from Bridgend, they will be able to go back there for their immunotherapy. As with all treatments, you always have to balance the side effects against the benefits, and this will be discussed by the oncologist. This is just the adjuvant regime, and essentially it's given to high intermediate, high risk, and those people with nodal disease, but it's all been resected. Treatment for the first 12 months and then followed up for 3 years by the oncologist. So that's my little spiel about surgery and essentially what you can expect. I know that Kath is on the line, and so she's just going to talk to the slide about the role of the key worker stroke CNS.
Hello. I'll try and talk slow because I'm Welsh and I know that some people might find it difficult to understand me. My name's Kath. I'm the prostate and kidney cancer clinical nurse specialist or key worker for Swansea Bay University Health Board. So just a little bit about me. I'm qualified in 2001 and I went to work on the urology ward. And I stayed there. I looked after many urology patients, including lots and lots of nephrectomy patients. I stayed in there till 2017 until I came into this role. So that's a bit about me and what I do. So just to talk a little bit then about the role of the clinical nurse specialist or key worker, because just to say that a key worker doesn't necessarily need to be a clinical nurse specialist. It can be your consultant, your GP, anybody can, have that role. So the main the main bit of that role is to be a support, okay, to the patient and the family. I try to go into clinic with the consultants at their initial consultation to introduce myself, talk a little bit about my role. That's not always possible, obviously, because of other work commitments. So if I'm not able to attend that appointment, my contact details are given to the patient and I try and contact them at a later stage. I find that sometimes more helpful, or the patients find that more helpful, because they may have gone away and a few days later, there's a number of questions that they've gone away and thought of, that their family members may have asked, may have thought of, and they can use that opportunity then to ask those questions. So that's it. So some patients I speak to quite regularly. They ring me every couple of weeks. They've got concerns, they're anxious. Some people I don't hear from at all. They've already got good family support. They don't feel that they need any additional support from me. So it varies from patient to patient. The benefit for the patient to have a point of contact is that they're not ringing around the houses looking for somebody when they've got a question. They're given the contact details of my secretary, who's fantastic. And sometimes she's able to answer the question because it may be that they're just ringing to chase up an appointment or find out where their scan is. And Amy's really good at that, just thought I'd mention her. She may be able to answer those questions. It may be that there's something that I can answer, or if I'm not able to, I'm able to go and find the consultant or one of the doctors to answer it. And again, if they've got any concerns following their operation, we bring them across to Morriston Hospital, the surgical assessment unit. We can see them there. We expedite scans if needed, if the patient's got new symptoms, all of those types of things. So I'm able to provide them with information and coordinate their care. It may be referring to the district nurses if needed. Some patients I refer down to, we've got a really good support centre in Swansea called the Maggie Centre. And some patients, they have need things with benefits advice if they're still working. They may find that their sort of managers in their job need a little bit more information in relation to what support they can offer to get the patients back to work. So I'm able to, help with that. There may be things like applying for a blue badge, insurances, holiday insurance. I get lots of queries like that. And I'm able to refer down to the Maggie Centre. We've got a benefits advisor there that can help with all of that type of thing. I also refer on to other specialist services. So it may be that initially that referral to the renal physicians is not required, but it may be that their kidney function does not improve, and I'll refer them on later on down the stage, later on down the pathway. So I follow up all of the kidney cancer patients, as well as the patients who are just under surveillance. I order their scans, I give the patient their result, and I refer on to any other specialties if something shows up on the scan. Let's see now. Put down a few notes, it's like in your mind goes blank. And I'll continue to offer support as needed. I also discharge patients. So that frees up the consultant because they're able to then see other patients. And the other thing is we manage it virtually. So it saves the patient having to come up to the hospital, the stress of trying to find a parking space. I'm sure you're all aware of that. Having to take time off work. I'll either ring the patient with the result of their scans, or I can write to them if they're stable. Some patients email me. It depends on what they require, really. And I've just mentioned there the evolving role of the CNS, because traditionally we would sit in clinic with the consultant, answer all the questions for the patient there. But obviously we're becoming more independent. I run my own nurse-led clinics now alongside Mr. Fenn. Obviously he's always there, but I discuss patients at the multidisciplinary team meeting. I'll refer on to oncology or the renal physicians, or scans show up, all sorts of things. I'll refer on to those specialties as well if required. So the role is evolving all of the time, and it's taking some of the responsibility away from the consultant to, like I said, free him up for other things. So that's a little bit about my role. Sorry if I garbled a bit. I waited so long. I'm a little bit anxious now myself.
Well done, Kath. That's absolutely fine. Yeah, and what you can see, hopefully see and hear from the talks is that this is very much a team approach. We put the patient very much at the centre of our care, and we try as best we can to surround them with everything that's required, both from the treatment options, taking them through the diagnosis, supporting they make the decision. Some patients are quite happy for us to say what we'd recommend, but
Yeah.
it's all one big team, and that's the only way you can work these days within the NHS. That's certainly the way forward, and I think that's for the for the benefit of the patients.
Yeah.
So just to bring this all together, then, what have we seen in the webinar to date? Well, that we can see that kidney cancer is common and sadly continues to increase in incidence. Lots of different reasons. Excuse me, whether that's environmental factors, other health things. Is it just the fact that people are living longer? So all these come together to unfortunately give us an increase in incidence. This incidental or early detection is now the majority of the way that patients present. Surgery or treatment, perhaps we should say, or surgery certainly remains the main treatment for localized disease. But the extent or the type of surgical approaches continues to evolve and is generally trying to be less invasive. And we see the advantages of that for the patient, far as needing to spend less time in hospital, having less complications, and trying to preserve as much renal function as possible. And there's one final thing to say, is which I've mentioned when we talk about surveillance. When I uttered my Hippocratic oath, one of the lines I had to repeat was first do no harm. And in many patients, although the incidence is increasing, there is certainly a role for no treatment or surveillance, and that may well be the best option for an individual group of patients. So thank you very much.
Thank you.
No, thank
There's a
you.
couple of questions there, isn't there?
Yeah, there is. So I think you've answered, Catherine, about the role of what a clinical nurse specialist is with your role as CNS. MDT, multidisciplinary team.
Disciplinary team meeting, yeah.
Yeah, so that's where all relevant healthcare professionals within somebody's care would come together to discuss the best options.
Yes, there will be the consultant, a clinical nurse specialist, a pathologist, radiologist, oncology are in that room. So everybody's discussing the patient and the best treatment for them.
Brilliant, thank you. And I think all the other acronyms were discussed at the point on the slide, but if there was any that anybody didn't understand, obviously feel free to put that in the chat. Just a reminder that ask your questions in the chat. If you do want to come on camera, you are being recorded, and this is being recorded to show later. So just so you're aware. So we have got another, like I say, we've got a couple in there. So to start off, if your tumour had grossly hemorrhaged, is it more likely cancerous cells will have broken off elsewhere in the body?
I'll pick that one up. I'm not muted, am I, at the moment?
No, you're not muted.
So if your tumor is grossly hemorrhaged, is it more likely? No. We do see tumors presenting with an internal bleed within it. What we know, of course, is that renal tumors are highly vascular. They have an overexpression of vascular endothelial growth factor, which is, of course, one of the targets to our systemic treatments, tyrosine kinase inhibitors. So generally, provided that hemorrhage is within the tumor itself, I'm not aware of any data which suggests that would be a worse prognosis for that individual patient.
Thank you. We've also got another question. If you have smoked for a long part of life, does that mean your chances are higher of reoccurrence as a moderate risk category anyway?
I'm not convinced that that's necessarily the case. I would imagine if you smoke for a long time or a long part of your life, then you're more likely to have other risk factors, other potential medical problems that may cause your health. The one thing I think that may impact on a little bit is if you were going to be one of those people in the high intermediate risk or high risk groups, when you're looking at looking at immunotherapy, there are some potential side effects, and of which your smoking history, lung disease may have an impact on whether you're offered adjuvant treatment. But no, I don't think that's a particularly worrying feature. But I should say at the same time, probably think about giving up smoking, but on general cardiovascular and respiratory grounds.
Okay, thank you. You may not be able to answer this one, but
Yeah.
has sorafenib been shown to not be effective? I had it 10 years ago on the SOURCE trial.
Yeah, so sorafenib is one of the tyrosine kinase inhibitors, and we do use it's no, so it's not that it's been not shown to be effective, all right. But in the source trial, there are a number of adjuvant treatments. None of the adjuvant studies showed a huge positive effect up until pazopanib and immunotherapy, and the sorafenib and pazopanib they work in slightly different ways. So no, it's not that it's not effective, it's just we've had further treatment developments.
Thank you. We've got another question in the Q&A section, and it says, thank you for tonight. It's been very informative. I'm actually in tomorrow morning for a radical at Monklands Hospital in Scotland. Can I ask, on average, for things like swimming, running, sauna, etc., how long do we think it will be until I can do these things? Thanks, Stevie Elliott.
So with the assumption that that's going to be a laparoscopic nephrectomy, i.e. keyhole, then I tell my patients 4 weeks to full convalescence, all right? So they'll walk into the hospital and they'll walk out. So that's not the issue, but getting back to full convalescence will normally take 4 weeks from the time of a laparoscopic nephrectomy. If it's an open nephrectomy, it's a bit longer. I think my record was a guy who ran his own business, was a mechanic. He came in to see me and he said he was under a car doing an MOT 2 weeks after his lap nephrectomy. So well, that may well have been driven by the fact it was his own business. But I think that 4 weeks to full convalescence. So we'd encourage you to be walking and simple exercise for those first week or so, and first couple of weeks. But and then slowly increasing your exercise tolerance over the 4 weeks, and by 4 weeks you should be able to do most of the things that you were doing before.
Yeah, he's
confirmed. Yeah.
And yeah, he's confirmed it is laparoscopic.
Yeah. So the advantage, as you saw from one of those slides, it is certainly a quicker recovery. Look, you're not going to feel to the patient. You're not going to feel like doing a great deal for the next few days, but once you settle down, once the discomfort of the extraction site particularly settles down, then your recovery will be so much quicker, because the incision is generally to extract the specimen. Will either be, if it's on a right side, will be an appendix type incision, or exactly the same on the opposite side for a left-sided tumor. These are muscle splitting cuts, and essentially are so much better tolerated than one of those big loin incisions up through the ribs. So best of luck, by the way.
Yeah, good luck.
Yeah. Somebody's put, what are the major side effects of adjuvant and immunotherapy?
Yeah, well, I'm gonna defer on this one, all right? Because I send them off to see the oncologists, all right? And to be fair, I think it's a great question, by the way, because the benefit has only been shown in the high risk of recurrence and the high intermediate risks. So Leibovitz scores 6 and above, I think that comes out as. And the reason being is that there is a side effect profile, and the way that the immunotherapy works, it's a checkpoint inhibitor. You have to be PD-L1 positive, but essentially it can trigger an immune response to many parts of the body that you don't want it to affect. So they can get a pneumonitis, they can get some GI upsets, but that will be discussed at length with CAS equivalents. So my equivalent, the oncologist, and also the oncology CNS. So we would ask that we package them up and send them in that direction.
Yeah, and I was just going to say, from a clinical nurse specialist point of view, I sort of deal with the surgical side, and then I've got an equivalent who works with the oncologist, and she looks after the patients with high risk disease or having immunotherapy or metastatic disease. But we work very closely together.
Thank you, because I know that's not necessarily your remit. So thank you. Got another question here. I had a radical nephrectomy over 10 years ago. Is my underlying tiredness related to losing a kidney?
well, it depends on how old you are now and what are the comorbidities. We know that if you take away a kidney, there may be an element of renal impairment, but and ultimately can be contributing to tiredness. But you're also 10 years older than you were when you had your surgery. You may have other comorbidities, so it's probably the fact you've had a previous nephrectomy and likely have an element of renal impairment will be a part of your contributing to your tiredness, but I suspect it's not the only cause.
Thank you. Another question: why is reoccurrence most likely in first 2 years of a radical, please?
Well, a recurrence generally will occur because there are tumor cells which have already spread prior to us removing the kidney, but our staging tests, as they currently stand, are only able to show a certain size of recurrence, so we're not able to pick up individual cells. And obviously, generally, therefore, if a recurrence is going to occur, generally it just occurs in those first few years because those cancer cells are growing away more slowly. So it's just a statistic. Having said that, and I'm not sure whether there's anybody in the audience today, one thing about renal tumors which are a bit peculiar is that you can get reoccurrences, sadly, many years later. And we recently changed our follow-up protocols throughout the UK and Europe. So we now follow up certainly the majority of intermediate and higher risk patients, even if they're of an immunotherapy or not, they'll be followed up for 10 years. But it's just the fact that essentially a reoccurrence is sadly a case whereby some tumor cells were there at the time of surgery, but just were too small for us to be picked up on our staging investigations. So just by definition, they're likely to show earlier rather than later.
Thank you. Got another question. This is the last question at the moment. So if anybody's got any more, if you start popping them in the chat now. But it is, I had stage 1B lung cancer 4 years ago. I had a partial nephrectomy on the 24th of September, grade 2. I have an 8mm hyperdense liver lesion currently waiting for an MRA. Is it possible to have come from the kidney or less likely with smaller kidney tumours?
So that's a very good question again. Generally, because obviously there's two factors. You told me the grade of the tumor, so the Furman grade, and so that's a lowish grade. So Furman grade 1, 2, 3, and 4. It's the size and grade of the renal tumor predict the chances of it being a metastatic spread from that. So I would say on balance, from the information that I've been provided with, not knowing the surgical margins of the partial nephrectomy and so forth, that it would be less likely to be coming from the kidney because of the size of the lesion plus the lowish Furman grade of grade 2.
Thank you for that. So for the moment, I was diagnosed T3B NOMO back in 2011 and cancer-free, and so I appreciate what you and your colleagues are doing, and thank you, KCOK, for this week. So
brilliant, lovely. And I mean, that's one of the things that when we're talking in clinical practice and in webinars, we always tend to concentrate sadly on the sort of the unhappy side of surgery, complications, recurrence. But what we also see is cases like that. T3B sounds vascular invasion, a lot of risk factors in there. And here we are 10 years later, that patient's, supporting the webinar and is hopefully living a completely normal life. And I think we must always try and just have a little memory for that, for those thoughts about those good outcomes, and that's really good.
Yeah. I think that another one. No, just a thanks again. So very interesting. Can the robot itself cause post-op issues? I had a radical nephrectomy in October, but the most aggravating complication has been acid reflux, which I never experienced previously. This wakes me up in early morning.
Lovely. Yeah. So first of all, a laparoscopic and a robotically assisted laparoscopic nephrectomy are essentially the same operation. In one, it's the surgeon that holds the instruments. In the other case, the robot holds the instruments, but the robot is a master-slave robot, so it does nothing on its own. All right, so it's not like Robbie the robot, like in Lost in Space. It does nothing without thing. All surgery has the potential for damage during the surgery, other organ damage. It's one of the risks that we will consent patients for. No, it's unlikely that the surgery per se is the cause of the gastroesophageal reflux disease. But of course, the stress of having an operation, the stress of a diagnosis of having cancer, and then that follow-up, that regular follow-up needing scans, and the concern that you get in those weeks before your scan and your blood test will probably more likely be having an effect on the production of acid and gastroesophageal reflux disease. And I would thoroughly recommend that patient goes to see their GP, because that can be easily treated with a proton pump inhibitor, lansoprazole type of drug, omeprazole, which you can get over the counter now. So antacid drugs, but it's worth just seeing the GP, just so they just get an assessment, or when they have their next follow-up with their urologist or CNS. But it's unlikely the operation per se caused it. And the robot, remember, I think we have a robot here in Swansea, and I've been doing robotic surgery in Cardiff for the last 10 years with regards to prostate. The robot does nothing on its own, all right? It's a master-slave robot. So the surgeon isn't having a cup of tea in the coffee room and the robot's doing the operation. The surgeon is physically there, watching every maneuver that the arms are doing, that the surgeon is telling the arms to do by remotely controlling them.
That's all we've got time for, I'm afraid, today. If you have any further questions following on from this email, you can either following on from this webinar even, you can either email hello@caseuk.org.uk, or there is the support email, which is support@caseuk.org.uk. Thank you both for joining us for our first webinar about Kidney Cancer Awareness Week. It's been really informative. Yes, again, just a massive thank you for Katherine and Niel for giving us your time today. It's been really, really informative. And thanks to everyone for joining us.
Thank you.
Bye now.